Good morning. Good morning, everybody, and welcome from the second section of the second day of the ELSA 2020 Virtual Congress. Thank you very much for joining us. Today, we have a sections, Women in Surgery, which I'm sure will be very exciting because I have 4 successful, beautiful lady surgeons from 4 different countries who are going to talk about their work and also their experiences in surgery. I now have together with me Prof. April Roslani, very famous colorectal surgeon from Malaysia, who will be, she will be the co-moderator for this section. So without further ado, since we have 4 speakers, and I'm sure you'll all be burning to ask questions to my speakers, I will start the first section straight away. So I would like to read a bit about Prof. April Roslani. Although she is a very known surgeon, she graduated from the University of Wales in 1995 and received the Master of Surgery from the University of Malaya in 2003. She had a training in colorectal surgical training with the National University Hospital, Singapore in 2007. She set up the colorectal surgery unit in University of Malaya and was appointed associate professor in 2009. She is currently professor, head of general and colorectal surgery. The colorectal surgery unit currently deals with the largest number of colorectal cases in the country. She is currently the treasurer for the Malayan Society of Colorectal Surgeons, honorary secretary for the College of Surgeons, Academy of Medicine of Malaysia. In addition, she sits on the National Subspecialty Training Committee for Colorectal Surgery. Through these roles, she works towards advancing colorectal surgical standards within the country. Prof. April, please.
Thanks very much, Momo. I think that the CV is a little bit out of date because positions have changed. Anyway, it's a pleasure to be here and to be here together with the other renowned surgeons. And I thought I would address an interesting topic this morning that's become very topical for us in surgery, but in particular in light of the current pandemic. So this is about occupational health hazards for surgeons, and to also try and address whether there are differences in the experience by determined by gender. All right, so these are my disclosures. When we talk about workplace injuries, for many of us, traditionally, we've just thought that they were part of the job. You know, but as we look at prolonging the longevity of surgeons and as occupational health has become a specialty of its own, we are starting to address whether these injuries are preventable, whether they're avoidable, and whether there is a gendered experience of workplace injuries. So when you talk about occupational health, we mainly address 3 domains, which are the physical, environmental, and psychosocial domains. And what I'd like to do is just address each of these, giving some examples, just as a platform for discussion. So when you think about physical injuries, they can be acute, and I think many of us are familiar with these, so I'm not going to address this again later on. What I'd like to talk about is the more chronic injuries, which are largely related to ergonomics with regards to the postures that surgeons adopt, but also the devices that we use, particularly as technology becomes an increasing part of our everyday practice. So I give you an example here of endoscopy. So these are your standard colonoscopes. And what you will see on the left-hand side is one of my male colleagues. And you can see he's holding the scope quite comfortably and is able to manipulate the dials without too much strain. On the right, you will see my hand. I use a 5.5 size glove. And while, yes, of course, you can manipulate it, it does require some strain and stress, particularly on the, say, the metacarpal phalangeal joints, you know, and with everyday use, year after year, this can certainly lead to wear and tear. This is another example. These are laparoscopic staplers, and you can see on the left-hand side, these are the non-powered manually applied staplers, and you can see that the angle of excursion is much greater compared to the right, which is a powered stapler, and the angle is much smaller, and it doesn't actually require physical strength to fire. Okay, so it's just a button mechanism. Does this matter? Well, actually it does. There have been a number of papers, and this is a good review article if you'd like to read it. And it shows that up to 85% of surgeons actually experience regular musculoskeletal discomfort, and in particularly with endoscopy, hand and finger injuries are experienced by 42% and neck pain by 11%, and I can certainly attest to that. But worse, it can lead to chronic disorders, and this increases with increased case volume, increased length of surgery, and if you've got this disproportionate ratio of the instruments to your hand, and it can lead to neuropraxia. The fact that our surgeries were often standing in a fixed position for a long duration, this actually increases the physical load on our bodies and leads to fatigue, and that can lead also to workplace injuries that are experienced by 40% of surgeons, and it actually affects their work. So either they have to take medical leave, you know, or they're having to reduce their workload, and this occurs in up to a third of surgeons. The sad thing is that most of us don't report our injuries, you know, so only 20% of those that experience injuries will actually report it. So they just kind of keep quiet and suffer in silence. And this has implications for the healthcare system in terms of economics as well as the risk of burnout. So I'm just going to show you this. You can see that the percentages of surgeons that experience pain in the various areas is high. I mean, 50% in the back, 48% in the neck. And this is for laparoscopic surgery, okay, those that are primarily laparoscopic surgeons. If you look at the open figures, you can see that they are much lower. So definitely laparoscopy and laparoscopic techniques places us at increased risk for these injuries. And you can see why in this diagram. This is what is touted to be the ideal posture. But can you keep this up for 3 or 4 hours, you know, at this optimal position? I can honestly say it's very hard to do. So then comes the robot, and is the robot actually able to minimize or improve the ergonomics so that you minimize injuries? The reality is that it actually changes the pattern of the injuries, but it doesn't necessarily prevent them altogether. Okay, so I'm going to move on now to environmental factors, and this is a nice paper regarding the occupational reproductive hazards for female surgeons. And I'm afraid we have to acknowledge that there is a higher rate of infertility and pregnancy complications in female surgeons compared to the general public. And while previous or earlier works tended to focus on the fact that female surgeons tended to have their pregnancies older and were working long hours, there are known environmental hazards as well, like the exposure to radiation, to surgical smoke, anesthetic gases, and toxic agents. You can argue that, you know, with filters, etc., you know, that we have reduced the risk of gas leakage. But I want to show you this very recent paper where they've used Schlieren optical imaging to demonstrate the extent of leak. And these are from new pots, okay? So these are not recycled pots. On the left, you can see an image which shows a leak when you intentionally open the tap. So when you want to desufflate, for instance, and you can see that you can see the plume that comes from the pot. On the right is actually an unintentional release of gas when we are introducing the instruments. So when you put the instruments in, can you see how much gas is actually expelled, okay? So whether or not you believe that this will lead to problems, health problems, it's been demonstrated there's significant gas leakage. And although the guidelines of many colleges and institutions around the world say that you can reduce it by keeping your pneumoperitoneal pressures low, this study has actually shown you get higher leak when you have low pressures. So I thought that was quite salutary. Okay, so what we have done in the era of COVID, as we mentioned in the pre-talk discussion, is that we've looked closely at scavenging systems. So you need to have a good filter. The HEPA filters, you need to have them able to filter out to an extent of 0.1 microns. And preferably you would connect it to a closed aerosol waste scavenging system. Okay, so that the entire system is closed. If you're doing a high pressure aerosolized procedure like PIPAC, you want to try and incorporate some sort of electrostatic precipitation device, which will further reduce the exposure to the air. Okay, so this is both with regards to infectious agents, but also with toxins like chemotherapy. And then, of course, we have to worry about PPE. And here we just have two examples. The one on the left is just with your standard N95 and a face shield. The one on the right is PAPR. But I want to just say that actually with all the PPEs, they're all kind of one size fits all. And unfortunately, a lot of times they don't fit women very well and puts them at increased risk. Finally, I'm just going to quickly address the psychosocial aspects. And this was a study looking at work injuries among young workers in focus group discussions. And we find that many of them experience injuries, but because of a perceived lack of control, they don't complain about it. If they do, their complaints are disregarded, and females are disregarded more than males. And many of the males actually choose not to complain. The other paper also says, although so far we seem to say that that women are disadvantaged, this paper suggests that actually the perceptions of masculinity mean that men are more likely not to complain and more likely to take risks that put them in danger and also increase the risk of accidents. In summary, I would like to say that we need better ergonomics in training, taking into account the gender differences. We need to design better devices that will prevent or at least minimize injuries. And our work safety programs also need to have a gendered approach. And thank you very much for listening.
Thank you, Prof. April, for keeping in time. Thank you very much. And we'll leave the Q&A section after all the speakers have finished presentations. So can you please invite the next speaker for the talk?
Okay, it will be my pleasure. And so our next speaker is Dr. Mina Shen, and Mina is the Chief of Colorectal Surgery in the China Medical University Hsinchu Hospital in Taiwan. She is a trained researcher, having obtained a PhD in the National Tsinghua University in Taiwan, and her interests are in minimally invasive surgery as well as advanced endoscopic therapy. I met Mina a couple of years ago, and I've always been impressed by her presentation. So I would like to invite her now to talk about gender equality in surgery. Mina, over to you. Mina, I think your mic is on mute. Your mic is on mute.
Okay.
Right, great, we can hear you now.
That's okay. So is the screen okay?
Yep.
So thank you for the invitation. I would like to share the experience and the review of gender inequality in surgery. I am a doctor of colorectal section, the chief of colorectal surgery in my hospital, and also a mom of 2 teenagers. More or less, gender inequality truly exists in the hospital, in medical field, and in the real world. In the past, in nowadays, and hopefully not in the future anymore. We cannot deny that medicine was constructed and handled mostly by men in the past, We cannot either deny that in the medical world, male was not used to work together with women, and no wonder most male physicians don't recognize that their female colleagues are usually treated unequally. Today I will try.
Nina, have you shared your screen?
Oh, yes.
Oh.
Didn't I?
Can anybody see your screen? I cannot. No, please share your screen.
Yes, yes, I will. I'm sorry.
Sorry to disturbing you.
I'm sorry. Is it okay?
Yes, that's fine. We can see
Okay
now.
Okay. So let me show my lovely kids. I'm a mom of 2 teenagers. And go on the speech. And no wonder most male physicians don't recognize that their female colleagues are usually treated unequally. Although medicine was male predominant at the past, nowadays in Europe, female physicians are already more than male physicians. In USA, 1/3 physicians are female, as well as 1/5 are female in Taiwan, in my country, and the numbers are still increasing. We have more and more female physicians, especially younger generations. However, although the number of female surgeons steadily increased in recent 20 years, but the percentage is still quite low. Is there a gender gap in performance? Does female physicians treat patients better or worse than male colleagues? This study in JAMA revealed that female physicians provide higher quality care and better outcomes than male physicians, with significantly lower mortality and readmission rate. A study of British Medical Journal compared the outcomes by male and female surgeons. About 100,000 patients were treated by 2,500 male surgeons and 7,700 female surgeons. Patients treated by female surgeons had a better outcomes, with a significant decrease in 30 days mortality rate. From Iceland to Taiwan, and from Germany to New Zealand, women are showing the world their ability. What do countries with best coronavirus response have in common? Women leaders. In Taiwan, you cannot believe that there is only 6 days in COVID-19 pandemic. Again, women are showing better performance. However, women's performance is not reflected on their salary. A study in incomes of physicians in the United States by race and sex revealed that female physicians earn significantly less than male counterparts. Black men physicians earn less than white men, but more than any race of women. Gender discrimination has deeper impact than race. One of the reasons for females' fewer salary may be the fewer working hours. However, even female physicians work full-time as male. Female doctors' earnings were 28% lower than their male counterparts. The salary gap happens from the beginning when female physicians finish their training and start their career. Some female physicians are lower productive in research and clinical work, and therefore have lower salary. They may not be related to their poor performance, but related to other unfair reasons, such as more household responsibilities, inequitable research funding and workspace, fewer mentors, and the preference on work-life balance. When female physicians are similarly productive, women still have fewer salary. Sometimes it is simply due to overt discrimination, but sometimes it is related to female physicians ourselves. We are less likely to receive recognition for our achievements and place less emphasis on salary negotiations. Most of the female physicians care about work-life balance. Gender equality is the less important issue. Sadly, 2/3 of female physicians are not skillful at negotiating for salary. Comparing to male surgeons, women surgeons have to do more childcare, meal planning, grocery shopping, and vacation planning at home. Female physicians have to do more housework. And female physicians are less able to maintain their family and more likely to get divorced than male physicians. If female physicians work harder, they divorce more. However, it is contrary in men. Male physicians work harder and divorce less. In marriage, women are not encouraged to pursue a successful career. Therefore, in the United States, as high as 25% of female surgeons remain single. The data from a non-formal study showed similar condition in Taiwan. Female Taiwanese physicians also have a high single rate, about 20%. In the United States, only 25% female physicians marry male physicians. Surprisingly, the ratio is as high as 65% in Taiwan. We can anticipate that Taiwanese female physicians would have higher incidence of work-home conflicts. This photo is the elected representatives of physicians in the biggest medical association in Taiwan. Disappointingly, although female accounts for 20% of physicians, there is only 2.5% positions for female representatives. Why are there fewer female leaders? When a woman exhibits her ability of leadership, she is usually considered as aggressive, show-off, and arrogant with a negative stereotype. However, men are likely to be thought as assertive, competent, and decisive. Women are less likely to benefit from networks with more senior male faculty and get promotion through it like other male counterparts, such as the drinking or golfing activities, and there is so-called old men's club. When women join these activities, there is a tendency to be regarded as an object or play doh. The other explanation of fewer female leaders is leaking pipe theory. Female is leaking from the pipeline and could not reach the end as a leader because women have other responsibility of housework and childbearing, lack mentorship, and the cruel fact that there are fewer leadership positions for women. This news happened recently that a study in the Journal of Vascular Surgery defined surgeons on professional behavior as drinking alcohol, using profane language, wearing Halloween costumes, and sharing bikini photos in social media. They announced that neither professional man nor woman post unprofessional content to their accounts. As a result, the hashtag #MadBikini became hot on Twitter or Instagram, as many female doctors posted their own bikini selfies in order to protest. Finally, this article was retracted and the authors apologized. This event highlighted the sexism problem in the medical field. Female physicians encounter gender discrimination such as disrespect and sexual harassment from every part in the medical field, not only from male physicians, from patients, but surprisingly, also from female nurses. The working environment for female physicians are obviously worse than male counterparts. Other examples of gender inequality are sharing duty room that is reserved for male, and as Professor Rosalani said, these medical devices are usually designed for men. So the suggestion for gender equality in surgery is, first, don't hesitate to protect and negotiate for our own rights. No one else will fight for us but ourselves. Find a mentor to follow. Be a mentor if you are able to, and encourage younger female colleagues. Participate in the leaders' positions and then improve the medical environment. In the end, I would like to show this photo again to encourage myself and all the female physicians. Although the gender inequality still exists and is hard to be resolved, Mrs. Women presidents are doing well. Let's follow their path and make us shining. Thank you, and welcome to our conference, ICISF webinar in Taiwan, holding in November 21 and 22. Thank you.
Thank you, Dr. Mina. It's a very, what do you say? It gives me a lot of ideas and thought in my head. Yeah, I think there'll be questions from the audience afterwards. Thank you very much for your talk.
Thank you.
I would like to invite the next speaker, Dr. Frances Lim from Singapore. She's going to talk about ways to teach MIS in era of disruption. She's from Dr. Frances from National University Hospital. Dr. Frances is a senior consultant from Division of Colorectal Surgery, Program Director, General Surgery Residency Program, University Surgical Cluster, National University or Hospital, Singapore. Dr. Frances, please.
Thank you. Can you guys hear me well? Okay.
Yeah, we can see.
Okay. So good morning. I'd like to thank the organizing committee for inviting me to give the talk at the Women's Surgery session. My topic today is to talk about ways to teach MIS in the era of disruption. Now, I thought teaching surgery is probably slightly more appropriate here because most of the surgery that we do these days are MIS. Now, over the next 10 minutes, I'm going to try to discuss gender differences in surgical training and not so much of differences in teaching in the time of COVID. Now, we have heard from Mina that we're far from being equitable. At our current pace, we will not reach equity for another 100 years. And there's still those who find the concept of woman as surgeon a novelty. So we ask, whose perception are we trying to change? Is that the public, the patient, our male colleague, or our female colleague? So my answer to you is that I think most importantly is for those who are coming after us, to tell them that it is possible. We need to change we need changes in workplace and culture, address the implicit and explicit bias at work, and we need to role model for our medical students and surgical trainees. So it's powerful to see someone just like yourself who doesn't have to try to fit in into the old boys club. It doesn't have the traditional image of a male surgeon succeed in having a fulfilling career. Hashtag I look like a surgeon is a social media campaign that started 3 years ago, and it has captured over 100 million impressions. It shows that the surgeons can in fact look like anyone. It is about challenging stereotypes, celebrating differences, and achieving equality in the workplace. If you look at the picture on the left, this is a New Yorker magazine poster on April 2017, and this has been replicated by women in many surgical departments. It celebrates diversity and inclusiveness. So I think it's important when it comes to discussion on gender equality to remember that it is not about female versus male. We're not against male. It is about how we can promote equal opportunity. It's not just about maternity leave, breastfeeding room, re-entry into career. It's how we can recognize our implicit and explicit bias and take the first step towards minimizing those effects. Having diverse people in leadership position and make sure that the role model and potential mentors are available. So these are some of the common comments that as medical student and young resident going through surgery, we hear this. And implicit bias in surgery is not a man's problem. I hear this from my female colleague and from my nurses. I have implicit bias on gender issue myself. I'm still learning to recognize and control them. So just the other day, I caught myself asking my male resident to go speak to a family who is a little bit more verbally abusive. And when I reflect back on that, I thought, explicitly, I'm protecting my female resident. But implicitly, what I'm saying is that, female are weaker in that kind of situation. So this is a nice study from the WashU group utilizing the implicit association test. Now, if you haven't done the test, I encourage you to try. The IAT is a well-known tool for measuring implicit bias. They survey over 400,000 healthcare professionals. Now, not surprisingly, both male and female participants were more likely to associate men with career and women with family. And if anything, female felt that more than men. And when they look at gender specialty IAT, for this, they survey 31 surgeons. And both male and female associate men with surgery and female with family medicine. So this illustrates my point that implicit bias is not just a man's issue. And so take a look at my program. We joined ACGMEI in 2020. And for the last 10 years, 31 of my graduates are women. 4 out of 6 of these women went into breast surgery. Okay, 1 GS and 1 left the program. The male graduate seems to have much wider interest. And this holds truth for the trainees who are currently in the program. So my question, so does a woman enjoy breast surgery more, or have we systematically nudged them into a field by biases rooted deep in our structure of our training? Perhaps unconsciously giving them more exposure to breast, more encouraging when they say they wanted to do breast surgery? Or is this a role modeling issue? In my department, we have 6 female surgeons. 3 out of 6 are breast surgeons, 1 general surgery and 1 colorectal surgeon. Our participating site have 1 female surgeon who's also a breast surgeon. So these simple figures illustrates the impact. Students and residents have difficulty visualizing a female HPB surgeon because they have never worked with one. And perhaps the implicit bias within my department has also systematically mentored the resident differently and contributed to this phenomenon. I'm encouraging my residents to rotate to other institutions for many reasons. And this is just one of those reasons that they need to be exposed to other female role models in other specialties in surgery. So it is important. So what I learned so far is that the inconvenient truth about implicit bias is that good people can unknowingly discriminate. And when this happens in medical school or residency training, it leads to restricted opportunity, harsher assessment, and it systematically push a certain group, in this case female, away from surgery or specialties or certain specialty within surgery. Let us look at surgery training. So female residents are a unique bunch. Why do I say that? These are talented young women, mentally tough. Along the way, they have encountered various forms of biases. They've been discouraged to go into surgery. And yet at the end of the day, they choose to do surgery. You can say they jump in with their eyes wide open. We know that concern about gender judgment affect residents' well-being. We know from US data that 67% of female residents experience discrimination with significant frequency. And the source of this discrimination, 60% of this come from male and 40% from women. The admin staff, the nursing staff are more likely to be female. We know that female residents reported working more fatigued, and also female residents reported feeling more unhappy and depressed and thinking themselves as more worthy. This is a recent publication on the topic by Sarah Mayers from Pittsburgh. It surveys 86 general surgery residents who are US graduates. But what it shows here, interestingly, is that the effect of pro-male bias on male and female residents were significantly different. It is reassuring to know from the study that pro-male bias doesn't have significant impact on female residents. The study actually suggests that the perception of pro-male bias promotes better performance among male residents, perhaps due to an expectation of privilege. This is in line with what we see on the ground. So the self-selected group of female, they are highly motivated, tough enough to withstand adverse environment. When they look at their subgroup analysis, they find that individuals with high susceptibility to steroid threat, okay? And they find that individual women with high susceptibility to steroid threat score lower on FLS assessment when they receive the threat trigger. Now they use FLS here as a surrogate for professional success. Not all individuals are vulnerable to negative stereotype and bias, okay? This tells us that if a susceptible individual in a negative environment, it could lead to less engagement, less reduced academic performance, burnout, and attrition. And the other interesting observation here is that men in the protection against steroid group, that means men who are told that women are as good as men in laparoscopy had a lower FLS score. I think overall this study gives a very positive vibe. It is multi-centered. At least in the 3 program that they survey, residents perceive no difference in the pro-male gender bias, the engagement, in the sense of belonging, in domain identification. They score no difference in FLS score, and female residents were found to be more resilient. So what are we doing in NUHS? So what can we do for those who are susceptible? So we have started personality testing for our 3rd-year resident. We have coaching session, follow on after that. We chose 3rd year because this is the year they transition from junior to senior residency, and they perhaps have the steepest learning curve. These results are confidential and not shared with the program. It is too early for me to tell if this is going to make a difference, but I do caution this identification of susceptible to stereotype threat. I worry that it will harm rather than help the resident in the long run. Some has proposed positive gender discrimination, but I don't think that is going to work for us, because if you have partiality towards a gender, it will result in lowering the standard and skills level for the graduate. Female graduate will have the misconception that they are not earned their place based on merit. So hence positive gender discrimination has not been generally implemented or accepted in our training. So how about skill acquisition? So we know from various studies, at the starting point, they might be different. Starting point, male seems to have more technical skill than female, but female responds very well to training. And at the end, they all get to the same level of, same skill level. The same with, how about autonomy? It seems like faculty give less autonomy to female residents. There's a wider gap when they ask residents to perceive the amount of autonomy they get. So operative autonomy was significantly related to case difficulty, gender, and level of training. Others have shown that male and female residents stratified by level of training has the same technical skill grading, but yet female residents have more intraoperative guidance. In endoscopy, study on endoscopy on FES shows similar result. Men seems to have better in the pre-training phase. Perhaps it's their hand size that is bigger, I'm not quite sure. But these differences even out once you give them training. There's, however, a confidence gap between gender differences in estimating surgical ability exist that do not reflect actual differences in performance. So as training program, we must be aware there's these potential differences and prepare to individualize their training based on their needs and learning styles of the training. And this is true for both male and female residents. How about evaluation? Men tends to receive more positive comment than women about their overall performance. So if you read out the slide, terrific resident, great job, versus good resident, good knowledge base. The two comments are representative of a trend in which men receive comment on their overall performance that were more positive. So terrific as opposed to good. More example, if you look at the top example, the passive tone referring to how she's seen makes this evaluation less strong than an evaluation of the same traits in the male resident. He's excellent. It's the term that is used. The use of superlatives tended to be more frequent in evaluation of male resident across the board. And I think you guys get the idea. And this is not unique to physician evaluation. I frequently observe this in our allied health evaluation. Women being assertive is frequently described as pushy, bitchy, not friendly, argumentative, while men are being described as assertive, take charge, leadership. This is true. It's not, and this problem is not created by men. We women sometimes have to look at ourselves and say, hey, are we being too harsh on some of our training? So it holds truth when I give feedback. Men are seen being tougher and better at handling criticism. Women are seen as inherently more sensitive and more fragile. So I often heard from my fellow core faculty and say, hey, why don't you talk to the woman? Assuming that because I'm a woman, therefore I'm more sensitive and I'm going to be able to give those feedback more effectively. Again, implicit bias. Lastly, I would like to share some observation about female residents with children. This figure was published last year. This is the American Board of Surgery pass rate. Look at the overall pass rate is identical for men and women. But compare the color bar. You look at the pass rate for men with children and women with children. It's staggering. The differences of these two charts is tenfold difference. So my conclusion to that is when you have no equality at home, you have no equality at work. Similar observation, the two curves are in the opposite direction. Being in the committed relationship protects men against emotional exhaustion, and thus the opposite for women. The same goes for having children. And in the COVID setting, if you look at one of the data that was shared with me earlier, you look at the number of COVID paper that is published by women and in the same period of time. Do you think women is less interested? I don't think so. I think it's because majority of the child care duty falls on women. And we have stay-home notice, home-based learning. Who's gonna do all those child care responsibility? Unfortunately, a lot of time it falls on women. So my conclusion, yes, the problem is the pipeline, but no, the problem is not just the pipeline. It is the process, okay? I think there's a great number of outstanding qualified female candidates to fill leadership position in university, hospital, major society, editorial board, grant review, and etc. The problem is the process that is heavily tainted by our implicit and explicit bias. In the context of residency training, having women in leadership positions serve as an important role model for the future resident. Although ideally, women need to see women mentor in leadership position. This will take some time for us to get there. We are still quite far away from that. Many of us women surgeons are mentored by men. Mentoring of women start with awareness of their issues and perhaps some variation of mentoring techniques. Do not assume, ask, beware of your own implicit and explicit bias, and encourage more diversity and inclusiveness in your workplace. Male and female residents should not be treated differently. They should be treated equally. We should adjust our teaching style to fit individual learners' need. Residents has to be treated with respect, take the gender out of the equation. And lastly, foster a healthy work environment. work on the issue that is pertaining to surgical training, hours, lack of family life, fatigue, service more than education, bullying rather than addressing the gender specifically. Lastly, I'd like to thank society leadership to bring awareness to this important issue. One last thing before I go is that most of what I have shared here are US data. There's really a lack of local data. We are very different from the US in terms of our culture, our upbringing, our home setting. I will look forward to collaborate with all those of you who are interested in this topic. Thank you.
Thanks very much, Francis. You've really unpacked a lot in a short amount of time, and you know, so much evidence already suggesting that we need to relook our own approach to our trainees. So thank you very much. I'm sure we'll have a lot to discuss later. We're going to move on to the next speaker, who is Dr. Tida Ong. Tida is a clinical professor at the University of Medicine II in Yangon, Myanmar, and she's also a senior consultant surgeon at the North Okalapa General Hospital in Yangon. I hope I pronounced that correctly. And she's well known in the region, and she's going to address leading a dual life, which sounds extremely interesting.
Good morning, ladies and gentlemen, and thank you, April. Can you see my screen?
Not yet. No, not yet.
Okay.
Can you share your screen?
I'm trying my best to do that.
Okay.
Please hold on.
Okay.
While we're waiting, perhaps we can try to address. Oh, there she's back.
There she is.
It doesn't start.
There's a share screen down there.
Yeah, I'm trying.
Stella, can you help us? Okay, we got it.
Okay. Good morning, ladies and gentlemen, and thank you, April, for the introduction. And actually, I have to thank Professor Momo, because as my boss, she forced me to take part in this talk. So I'm trying to talk about the living a double life. Like we women surgeons have to operate in different kinds of operations in our OT and our work, and have to do different kinds of household chores in our daily life. Actually, we are called super mom. So I like the name super mom better than anything. So as two previous speakers talk, we have so many barriers to pursuing a career in surgery. This is an institutional survey of Harvard Medical School, and 75% of students pursuing surgery reported verbal discouragement from pursuing a surgical career, and especially women are more likely to perceive discouragement regarding gender, age, family aspirations. And more women reported concerns about time to date or marry, time to spend time with family, finding time during residency to have a child, taking maternity leave during residency, and being too old after residency to have a child. So 14% of female medical graduates choose surgery, whereas 33% of male graduates choose surgery. So there are so many struggles of female surgeons in the male-dominated world, as my two previous speakers said. Female surgeons who also play a role of mother may find it hard to give their best in both their careers and their family lives, leading to a greater amount of guilt and feeling of inadequacy. And female surgeons also express having to face more pressure and discrimination in their workplace, such as patients mistaking them for nurses and their male colleagues offhandedly throwing discriminatory remarks at them. So does every woman surgeon feel the same way? So it looks like we mostly feel the same way, because as Mina and Francis said, the gender discrimination is everywhere. But there's a study done by American College, in General American College of Surgeons, regarding career satisfaction of women in surgery. They study both the male and female surgeons well into their surgical practice, at least 8 to 10 years, and both were satisfied with their surgical profession. And especially the ladies, their perception of whether the surgery is a good career for women. Most women think the surgical career is good for women. And they have many trade-offs to make to balance between the surgeon's life and the household life. So most women are satisfied with the surgical profession because they have personal time, predictable time, and family relationship. They prefer more on that, and men prefer more on the surgical profession, as in good training and compensations. So these are the trade-offs women has to make, like giving up the desire to do surgical oncology fellowship because to be with the husband, and make less in private practice but enjoy other features of current career, but write less paper than before but enjoy autonomy at current positions. So there's a Japanese study for analysis of gender-based differences among surgeons. It is performed by Japan Surgical Society, and more than 5,000 men and 600 women surveyed in 2014. And surgeons generally prioritize work and spend most of the time at work, but women with children prioritize their family over work, spending more hours on domestic work or childcare. But both genders still think that, like traditionally, women should bear primary responsibility for the family. So our men surgeons really think women are beneath them. So 80% believe it is possible for a woman to be both a good surgeon and good mother, while 13% disagree. But in case of men, 96% agree that a man can be a good surgeon and a good father, and 0% disagree. And 46% believe having children adversely affect a woman surgeon's ability to succeed professionally. But 81% of them believe it is not effective for men. And 84% believe women have more pressure to balance work and family. But 57% mentioned that they would not mind covering for us women surgeons who took time off for maternity leave. And 44% believe patients treat women surgeons differently than men, but older surgeons more likely to believe women surgeons have better interaction with the patients. So there's an article about the approaches of the lady surgeon written by a lady surgeon. And one approach is she can become one of the guys. So she can get treated as a gender neutral. And alternatively, a woman surgeon can adopt almost a caricature of traditional female role, seductive and helpless. And lastly, she may feel compelled to prove herself as a unquestionably competent at both family and home, that is having it all. But I don't think none of you guys would agree with the second option, because we women surgeons don't usually do second option. So a few things about my personal life. I got married at a few years after graduation from medical school, and I have my elder son next year. So when I was in surgical rotation, I have to look after my 2-year-old son, and I have to look after my postgraduate medical student husband. So I have to live with my parents, and they both look after me and my family very well. So I think I didn't have much problem with the financial things, but I have to juggle everything between young son and family life and my surgical rotations. But luckily, I have very good teachers who never treated me differently. The only thing I have gender discrimination was when one of my professors asked me to assist him in OT, which lasts about 4 hours long. And at that time, during the operation, he said, that's why I don't like women to assist me, because women are not fit to assist for long operations. But I proved him wrong. So I think that's the only time I had gender discrimination from my teachers. They were very good on me. And I have wonderful colleagues who thought I was one of them. And they even take my on-calls when my son was ill. And when you have trouble is when one of your family members fell ill. That is also true even at this stage. And I still have to do a lot of balances between work and family, and I have to multitask every time. But I think I'm lucky to have an understanding family and a very good workforce. But when I ask my sons about their perception of me, working very hard and not very much with them. So especially my younger son said they were feeling lonely at home when they were young, and they would like to have more family vacations with us because we both were very busy. But the positive effect they said was they were proud of me. They thought I was a great role model and a mother stroke best friend they can count on. So thank God. And I like to give a few advices for the professional life, but it's not only from me, but from some of the lady surgeons. You have to have a good mentor and patient and helpful colleagues and a very best friend to talk to. Like in my case, I have Momo to talk to. And you have to work not hard, but smart with good stamina, and you have to choose the specialty carefully. Even if you want to have very demanding specialties like cardiothoracic, you can choose, but you have to balance. Because one of my friend is in a professor of cardiothoracic surgeon, and she's also have 2 sons like me. So work-life balance is very important, and you have sometimes to multitask. And what about marriage for the single ladies? I think you have to make sure you want to get married and he's the one, because the understanding between the two of you is very important. I'm not sure what to advise about the age of marriage, because I married early, and when I started surgical rotation, I have to jump in to the surgical rotation with both the family to juggle. So I'm not sure how to suggest. So you have to decide for yourself, and that's also true for the age to start family. And advice for the family, one more thing, this is very important. She asked me to do, this is very important, marry an excellent husband and keep your kids healthy, and accept help from other family members in childcare and hire help if you can afford it, like childcare, cleaning, laundry, and cooking. And take mini vacations or vacations with your family. The important thing is make time for yourself. Sometimes you forget to make time for yourself. And this is a few good things about work-life balance. This is not an entitlement or benefit. You have to create it for yourself by one of the authors. And this is from former First Lady of the United States, Michelle Obama. The essence is we have to put ourselves higher on our own to-do list. By that, thank you very much.
Thank you very much, Tida. That was a very good overview of, the challenges we face and how you've managed to overcome it. But obviously, everything is still in evolution, isn't it? It's a work in progress, and we have to help each other find our way. So, Momo, we have lots of time for discussion.
Yeah, I think we have quite some time for discussion. I'm very glad that I pushed Tida to give a talk on this. You did a great job. Yeah, and I think we learned a lot today from each other's. Yeah, April, what do you think?
Yeah, definitely, and I can see from the chat line as well that there are quite a few questions already from some of the earlier sessions. So maybe we'll start off with a question about how to create positive relationships between male and female surgeons and a friendlier work environment. So perhaps I can address that first to Mina, and then we'll go around the panel. Just give your opinion about that. How to foster a positive work environment, which is gender neutral.
I never think that question before, because it didn't bother me.
Right. So you work in a very positive work environment.
Yeah.
What are some of the positive behaviors? Because from my understanding, in Taiwan, amongst your colorectal surgery, right? So amongst colorectal surgeons, it's still mainly male dominated.
Yes. For now, only 15 female colorectal surgeons among about 500. Well, the percentage is quite low.
And yet you say it's a positive work environment. So can you give us some examples of how your colleagues, have created that environment?
I have to say I'm lucky. I didn't encounter the obvious gender inequality during my training, during my clinical work. Have you ever treated equally?
Right. And I also realized that some of your senior colleagues, they're actually quite proactive in encouraging female participation in surgery as a career. Because I remember a session in Taiwan where female trainees and medical students were actually encouraged to give presentation. So I think there's a lot to be said for mentorship and also sponsorship.
Yes.
You know,
Yes.
from that. Francis, what about in Singapore? I mean, you did mention some things with regard to training, but what about career development in general? Do you think it's still very male dominated? Is the work environment improving generally?
I think we've come a long way, for sure. But I think, in my mind, I think realizing that all of us hold some form of implicit bias, be aware of that, and then commit to that shift, that change. I think that will go a long way. So I think at a university level at this point, there are a lot of talks ongoing about educating the senior leadership, and me trying to educate my faculty about some of this implicit and explicit bias. At the end of the day, we all have a choice. I mean, people always come to me and say, but it's a choice. I mean, you choose to have children, you choose to take time off, and it's a choice. I'm all for the choices. What I'm saying is that you have to be mindful of your own implicit and explicit bias. Just because I make a choice doesn't mean that I want to be assumed of a certain role. So that one thing will help, and I think role modeling will certainly help. We might have to, there's no right way to put this out there, but we might have to actively look at when we have search committee looking for heads, when we have society looking for president and etc. We might have to really put in that little bit more effort to say, look, can we create a more gender balanced environment? When we look at society speakers, for example, recently there's a social media tweet that's been going around mocking one of the Asian cardiothoracic society, because all male panel and the topic was women in surgery. There's nothing wrong with that. As I say, I mean, women are mentored by men, but it's just that it sends a very wrong message. It set up a very poor starting point for young women starting out in the field.
Yeah, I think a lot of it is actually just lack of awareness and attention to detail, because I know I've worked in many scientific committees, and the tendency is that you choose or you plan to invite people that you know, or people who are, have a high public profile, and unfortunately, because often the committees themselves are predominantly male, they tend to think of male colleagues. And sometimes as the sole woman at the table, you do need to speak up and say, are there really no competent, capable women? And then I'll come up with a list of people and they'll say, wow, yeah, actually this person is really good, right? So I think it's just lack of awareness and perhaps, just being in their comfort zone. And sometimes you have to disrupt that a little bit or a lot. Yeah, so we certainly find that in our conferences when we're trying to establish panels, they end up being manels, as that term is going around in social media. And so again, I'm not saying that you should enforce that it has to be a certain proportion, but at least think about whether there is whether you can make your panels more diverse. I think that's the key. Diversity is always works towards a healthier environment. Having said that, and I'd like your opinion on this to the rest of the panel. Sometimes when you want to disrupt things dramatically, or when there's a need for a rapid change, it does require some top-down policies. So certainly in Malaysia, we have nationally, there is a mandate to try and increase the proportion of women in top management to at least 30%. And since that came into place, you certainly see a lot more, and they're very capable. I'm not saying that you just put them there to fulfill a certain quota. So I'm not in favor of quota systems. But I think we should be, the idea is to get you to think, are there people who might fulfill this and are capable and competent to do it? So what do you think about that top-down mandates or policies? Do you think it's helpful?
I think you started to see that in a lot of major society in the US. I think they have a lot of the society has come out and openly say that they will mandate equal representation. It's not just the women, it's about diversity. How about the rest of the minorities? It's not just women. I think and US is also moving that direction. We now have a very strong work group in Women in Science. I think we will see positive changes in that direction. And hopefully with this, you have more women surgeons in the leadership. And that will create a role model that will stop us from our leaking pipeline, the glass ceiling, sticky floor issues, and get us more represented.
Tida, how about in Myanmar? Do you have any similar sort of policies, either institutionally or nationally?
Actually, not nationally or institutionally, but at the moment we have 5 medical universities and 5 professors and heads of surgery. 2 of them are women. So 2 out of 5 professors and head of surgery are women. So we have like 40% ladies heading the surgical field. So that's not very bad. And in training, more and more lady surgeons coming into the surgical field. So we have like 50% of surgical trainees are ladies. So I think we are not in very bad situation. And when I find that the ladies are more intensive in training, and they give they're all in the training. So if they really try hard, like at the moment, they will be more successful than us, I think. I don't know, what about Momo's opinion?
I totally agree with you. I mean, if I say that ladies are very intensive than men, then the junior colleagues or the colleagues around me, maybe they'll be mad at me. But I think if ladies had a mind to go ahead, they really go ahead. If they set their mind to do it, they really do it. So they have a lot of determination. I don't know about the other places, but we ladies, because you are living a double life, you try to work out for your work, for your families, and also because I have 2 successful friends, Tida, Winjo, and a lot. They are very successful surgeons as well as also with their family, because they can handle both the life well. And like them, they are mentor for the younger generations. They also think, okay, so if Mama Tida can do, if others can do, we can also do. So there is some part of mentorship also. We have a question for Tida as well. Maybe it will be difficult for you to answer. How to define an excellent husband? Could you tell us your perspective? How to define an excellent husband?
Understanding is the most important thing, because he has to understand me doing my work. Sometimes I have some deficiencies at home. Whenever I try to emphasize on my work, like I forgot to iron his shirts, so he can understand that. But I try to repay him with the more care. So understanding is the best thing, and I think another best thing is the actually his salary is more than me because he works double time than me. So that is also important because I can do what I like at home without having to worry about money. So that's all. That is also important, I think. So there are so many excellent things about him, but I rather not talk here.
I thought excellent husband comes from excellent wife.
Every successful man has a supporting lady at home.
But I agree that. I think Prof. April agree.
Yeah, well, I think marriage is a partnership, isn't it? And it's got to be a partnership of equals. I don't think there is a monopoly by one party or other into the responsibilities of creating a harmonious family or making sure that it all works well. Certainly in my family, I don't think you could say that one of us is the main homemaker, one of us is the main income earner, etc. Because throughout the course of our marriage, it's shifted. The balance has shifted both ways. There have been occasions where he has been the main income earner. There's been other occasions where I have been the main income earner, and depending on what our job situation is like, the one who has a less intensive job will take on a bit more of the home responsibilities, but we do everything. I don't iron his shirts. He irons his own. So it's shared across the board, whether it's housework, cooking, looking after the children, even looking after older family members, who has the responsibility to bring them to and from their clinic appointments. It's shared. Everything is shared. And that to me is an excellent husband.
I have a questions to all the speakers. I think any one of you can answer this. I think I read in one of the slides, discrimination to the ladies. Yeah, 40% sources are from ladies. Am I correct? So how do we overcome or make it less? I cannot say erase it. What's your suggestions?
Well, it's cultural, isn't it? We have a surgical culture, and culture, whether it's surgical or in the public, it's not something easy to change, and it needs a combination of bottoms up and a top down approach. So top down would be having policies where it's actually not permissible to discriminate, and that there are robust processes in place to address any complaints or misdemeanors, and people have to be willing to do the hard work of ensuring transgressions are actually, that there are consequences to transgressions. That's not something easy to do, but I think it's incumbent on institutions to do so. Okay, so that's a top-down kind of thing, but almost more important is the bottoms up. You have to actually change the culture on the ground. We've done some work looking at oppressive behaviors in the workplace, and it's actually not the consultants bullying the house officers or the medical officers. They're bullying amongst themselves. Like the senior house officer will bully the house officer, and so on. So for us as role models, we have to say to them, this is not acceptable. And my trainees know this is not acceptable. And we will even, extend them in the program, send them for remedial classes and all that, to teach them how to behave, how to treat everyone with respect. So it's not easy. And I don't think I want to say it's a woman thing or a man thing, because if you've grown up having role models that treated other people with disrespect, you would tend to mirror those behaviors as well. So if you were maybe a woman surgeon training say 20 years ago, virtually everybody around you is going to be male, and if they exhibit toxic behaviors, you would think, well, that is the way to be an excellent surgeon. You have to be like this. And so we're actually trying to change those behaviors, and we've incorporated that into the curriculum as well. You know, we've got a whole section on professional behaviors.
Francis?
I think that's why this kind of session and dialogues become very useful. You raise awareness. It's not just about among women, also among men and women. Because I have to say, reflecting on my own journey, I'm very fortunate to always have very good female role models. I come from a training program where women are chair of vascular surgery, chair of thoracic surgery. Women subsequently become American College of Surgeon president. So that kind of role model, that kind of help you grow up in a surgical environment to expect that, I would say, to be willing to take in less bias, less beating as a woman in a way. So I think that role modeling is very important. And I think us having this dialogue will make a difference for those that is coming behind us. And the other thing is, I think it's very powerful with social media. If you look at movement like he for she, like I look like a surgeon and this is what we look like. These are all the social media movement that is very encouraging for those coming behind us. They look at this, they say, hey, you know, we don't really have to behave or be in the old boys club. We can be ourselves. We can be nice to each other. We can be the girly girl that we want to be and yet be a surgeon. And so I agree with April, top down and bottoms up, and they're both important.
Thank you. Nina, do you want to add anything?
Yes. I keep on recall the question about positive relationship between you and your colleagues. I think the basic concept is respect. With respect, we can treat each other well, either from female and from male. And it's kind of culture. And I think this kind of discussion and section will change the culture gradually and to construct a better environment for both men and women. And about the discrimination from female colleagues and from female nurses, I think we as we are female surgeons, we usually encounter this problem when we were young. And at our age, we seldom feel the discrimination norm. And I think the major point is confidence. If you are confident, you can overcome this situation. And this confidence needs to be built up either by the role model, by the experience sharing, and by growing of our own ability. It needs some external help from the role model and from our improvement of ourselves. And that's my answer, the respect and the confidence.
Yeah, absolutely agree. It is all about respect. And I think if we just have that as our springboard, you know, everything else will fall naturally into place.
Yeah.
I think we have a little bit more time, and I just wanted to address one of the more technical questions from the audience, and this was about whether companies or organizations are improving ergonomics for women laparoscopic surgeons in general. And I'm going to ask the panel as well. I mean, in general, I would say that certain developments have helped, like the powered devices, button activated, but you know that was actually not a gender-specific change. It was actually just because generally surgeons find there's a problem, and so it wasn't specifically developed because of women surgeons. Is anyone else on the panel aware of gender-specific developments in devices?
I'm aware of, yeah.
I'm not aware. No, I'm not aware of that either. And would you say that we need some devices later on? Would you?
Well, I think again, going back to the theme of diversity, you know, there are surgeons of all sizes and shapes, and you know, so regardless of whether you're male or female, I think the companies, the device company, should be looking at providing a range of equipment, including PPE. I mean, it's true. I use PPE and PAPRs, and just one size fits all. You know, and we've all got different head sizes, and the weight bearing of the PAPR, that's quite cumbersome. So I think moving forward, I think pandemics aren't really going to go away just because of the way the world is today. So the companies do need to put in a bit of research and development into this area. Customizable equipment.
I think the equipment issue doesn't have to be gender specific. I think you're right. It's about, I don't know, taking into account different sizes. I mean, most of the equipment are designed for Western male surgeon, size 7.5, 8.5 hands. But the fact is, a lot of our Asian surgeons, whether men or female, just does not have that kind of a hand size. So I hope it will come, but I haven't seen anything in the market. But one of the things that I tell my residents is to acknowledge their difficulties. It's okay. I mean, at this day, I still get laughed at by my partner that I need 2 hands to fire an EEA. It's fine. I don't have that strength. I cannot do my EEA one-handed, so be it. But it's to be comfortable, acknowledge and seek help, find variation, talk to other people, see how they do it, and then make it safe for your patient. But I really hope that down the road, we'll see some different sizes or different mechanism that doesn't take hand strength and size into as much consideration.
So if there are any representatives from industrial organizations out there, hear us. We want diversity in your equipment. We're happy, all of us happy to work with you towards that objective.
Yeah.
We're coming up to the end of our time.
I think we still have some time left. I would like to add something about what Tida has mentioned about the situation in our country. Because I think at the moment we have a very good situation for lady surgeons in Myanmar. Because out of 14 general surgeons, professors, 6 professors were ladies. Ladies, they are still working. And then out of the 7 specialties like hepatobiliary, cardiothoracic, pediatric, and plastic and maxillofacial, the professor and head are all ladies. So I think for our countries, ladies are doing a great job. Thanks to the men who are supporting us. Yeah, I would like to add that. And thanks to our mentor, because without these mentor, we ladies cannot be where we are. So that we have our mentors, both male and female, to thank for that. I would like to take this opportunity to thank all our mentors. And I think we still have about 5 minutes left. Any burning issues that you want to address? Yeah, Francis, please.
I have a question for the rest of the panel. What do you think of my residents' preferential choices for breast surgery? Do you think I have do you think this do you see that in your own institution? Female surgical trainees gravitate towards breast surgery? Or do you think this is something more systematic? I would love to hear your opinion on this.
So in Malaysia, if you go to the National Specialist Registry, about 65% of breast and endocrine surgeons are female. It's probably the only specialty where the reversal of proportions is so great. The other one is for some strange reason, in peds surgery and in plastics. But the proportions are not quite as great as that. I think a large part of it is the perception that work-life balance is better. It is also the role models, because obviously if you see more women as breast surgeons, you think, well, that's probably something that's more suited to me. And unfortunately, even our male colleagues seem to have that perception. And therefore, if they are in a mentorship role, they may tend to either consciously or unconsciously sort of direct their female trainees towards that pathway. I recall one of my trainees previously who, after she had passed her general surgical exams, she had rotated to my team, and I knew that she had sort of been earmarked to be in breast surgery, right? So I just asked her one day, so why do you want to do breast surgery? And she was silent for the longest time, you know, and she couldn't actually tell me why. And she actually verbalized that. She said, I don't know why. So anyway, at the end of her rotation with us, she had decided to become a colorectal surgeon, and she's a colorectal surgeon.
Thank you very much, ladies. I think the situation is a sort of a reverse in our countries. Ladies want to do a hepatobiliary and a colorectal also, of course, because we are there. But I think we need to discuss it further because now we have to close our sections. The time is up, and thank you, ladies. Thank you very much, Prof. April, Mina, Francis, and of course, my best friend, Theda, for volunteering to be part of these sections and giving a talk and showing the world what we lady surgeons are standing and will stay stand and go up. Thank you very much. I hope you enjoy the section.
Thank you.